Hi again, everyone. Thank you for joining tonight's webinar, Causes of DCM and Stages of Heart Failure, presented by the DCM Foundation. We're so glad you could join us tonight. We see some folks are still coming on, so give them another few minutes. Just a reminder that all of the recordings of all of our past webinars are also available on our website at dcmfoundation.org. So you may want to go there and check out some of the other events that we've held over the past year. We do hold these webinars monthly. So let's get rolling. First of all, just a reminder for folks, our mission is to provide hope and support to patients and families with dilated cardiomyopathy through research, advocacy, and education. I will be your host tonight. My name is Jayanne Rock, and I'm the Director of Information and Education for the Foundation. We do ask that you please submit your questions at any time during the presentation. We will have a dedicated Q&A session after tonight's speaker, so please feel free to drop those in at any point. If a question pops into your mind, just drop it right into that chat Q&A feature at the bottom of your screen. Next slide. First, we're going to do a quick poll, as we always do, to find out who is attending tonight's webinar. Please select whichever best describes you. Are you a patient, family member or friend, medical professional, or industry professional? Just give it another couple seconds here. Excellent. Okay, let's end the poll and share the results. Nice. Nice mixture here. So this is great. More than half of the folks attending tonight are patients. And then we have a nice mixture of family members, industry professionals, and even some medical professionals. So welcome to tonight's webinar. Again, we very much look forward to having your questions. Please drop your questions in because this promises to be a great event. We have had so many requests for this topic over the past year on the causes of DCM and stages of heart failure. So let's get rolling. Next slide. Perfect. Thank you. Tonight's speaker is Dr. Kathy Crispell. Dr. Crispell is a cardiovascular disease and advanced heart failure and transplant specialist. She did her cardiovascular training at Oregon Health Sciences University in Portland, Oregon, where she participated in research with Dr. Hirschberger studying DCM in families. She was later recruited by Northwest Kaiser Permanente, where she served in roles as the Chief of Cardiology, Director of Cardiovascular Services, and Chief Medical Officer. Dr. Crispell retired from KPNW in 2015, but continued to work part-time at the Portland VA Medical Center and at OHSU as an adjunct associate professor. Additionally, she has been a volunteer physician in Myanmar and Ethiopia and provides telemedicine cardiovascular consultation to remote clinicians in Oregon and Washington. We are thrilled to have Dr. Crispell with us tonight. So without further ado, Dr. Crispell, the floor is yours. Thank you.
Thank you, Jayanne, for the very nice introduction, and welcome to our audience. It's nice to be back with you again this afternoon and this evening. Well, as Jayanne said, we get numerous questions about these topics, and that's why we're having this webinar tonight. And so we'll begin with a brief overview of DCM, and I'm sure many of you already know this, so forgive me, but there may be some of you who do not know this. But DCM is an acronym for dilated cardiomyopathy. Dilated meaning enlargement, so at least the left ventricle of the heart enlarges, and as it enlarges, the heart muscle thins out. Other chambers of the heart can also dilate, but at minimum, the left ventricle needs to dilate. And cardio means heart, and myopathy means muscle disease. So dilated heart muscle disease. So that's really what dilated cardiomyopathy is. Associated with this dilatation and this thinning of the heart muscle, there is also dysfunction of the contractile function of the heart as well. And we measure that clinically using the ejection fraction, which I'm sure many of you are very familiar with that term. So that's how we measure the ability of the heart to contract. So, so on the upper right corner of this diagram is a heart with dilated cardiomyopathy. And if you compare that to the heart on the left, which is a normal heart, you see that the left chamber is much enlarged, and the heart muscle itself is thinned out as compared to the normal heart here. Now, there are other types of cardiomyopathies. Many of you probably are familiar with hypertrophic cardiomyopathy, where the left ventricular chamber is actually smaller than normal and the heart muscle is very thick. But we're going to focus most of our attention today on dilated cardiomyopathy. Whoops. Can we go back one? I'm sorry. Can we go back one? There, thank you. All right. So we'll start off with describing the common causes for dilated cardiomyopathy. And I think of the common causes as kind of falling into two really big categories. The first really big category is what we call coronary artery disease or ischemic heart disease. These are interchangeable terms. And about half or a little more than half of all people who have dilated cardiomyopathy in the Western world have coronary artery disease as the cause of their dilated cardiomyopathy. And then the other half, or close to it, is what we call non-ischemic causes. Basically, a bunch of different diseases that aren't coronary artery disease or ischemic heart disease. And most of those other kinds of diseases fall into this category that we call idiopathic, which idio means, we don't know, and pathic is the disease. So we don't know the cause for the dilated cardiomyopathy. But this is kind of based on older information. We know nowadays that at least a third to half of people that have been diagnosed with idiopathic dilated cardiomyopathy actually have a genetic cause. So I've kind of clumped them in under the idiopathic, but it's just letting you know that at least a third to half actually have a genetic cause, and we know that today. And it's possible that even more have a genetic cause, and we just haven't identified those genetic mutations yet. But as science evolves and we learn more information, I bet you that this percentage will increase. And then a small percentage of these non-ischemic non-ischemic causes, about 10%, so a small number, are from other causes. And I have a slide that shows you some of those causes. Okay, so since half or more than half is really from coronary artery disease, I thought I'd spend a few minutes just discussing with you what coronary artery disease is. This is actually a CT image of a normal heart, and these white squiggly lines on the surface of the heart are called coronary arteries. These are the arteries that feed the blood supply to the heart muscle itself. So these are very important arteries. And since the heart is a big muscle that's always working, it started working before you were born, and it doesn't stop working until the moment we die. And so the heart muscle needs a good blood supply. So these are very important arteries. It's supplying the heart muscle its oxygen and nutrients. Now, arteries are blood vessels, and they are made up of 3 layers to these blood vessels. So and that's important because in coronary artery disease, lipid and cholesterol gets built up inside the layers of the artery. And if the buildup is real severe, it can actually, decrease the size of the lumen of the artery and decrease the amount of blood flowing through that artery. And a symptom of that could be angina or angina. That's a symptom that not enough blood is getting through the arteries and feeding the heart muscle. Another problem associated with this lipid deposition and cholesterol deposition in the wall of the artery is it can actually eat through the inner wall of the artery or erode through the inner wall of the artery. And when that happens, the body knows that, and the body sends a bunch of special cells to that area of injury of the arterial wall, and it tries to start the healing process, and it tries to patch it up. And one of the first things it does is it forms a blood clot over that site of injury. And if the blood clot is large enough, that can obstruct the blood flow altogether through the lumen of the artery. And that is what the cause of most heart attacks or myocardial infarctions is in the Western world. These are some other CT images of the heart. In this image on the left, the coronary arteries, we don't see all of them, but we see a couple of them. Here's one, they're white, okay, for the most part. But if you look where the arrow is, you kind of see it looks like there's been a bite taken out of this artery right here. Well, that's because that's where a big cholesterol plaque is. And it has actually narrowed the lumen of the artery right there. And you can see that it's narrowed. You see the same thing in this image B, which is another CT scan. And again, the artery this is a magnified image, and the artery here is in white. And you see this black thing right here, and the lumen of the artery is narrowed right there. That's because this is a big cholesterol plaque that's narrowing the artery. And down here in image C is a coronary angiogram. And instead of the arteries being white, they appear to be black in this image. And here, let me just point out this artery here on the right. It looks rather smooth, okay, that's good. That's what we want. There aren't any severe blockages or cholesterol plaque here in this artery. But if you look at this artery here at top and where the arrow is pointing to, you can see again, it looks like there's kind of a divot taken out of the artery, and that's where there's a big plaque, and it has narrowed the artery. And you can see in this whole section of the artery, it's very lumpy, bumpy, very irregular, and that's because there's a lot of cholesterol plaque in the course of this artery in this section. Now, I mentioned that if the heart or if the blood supply is interrupted altogether, that can cause a heart attack or a myocardial infarction. And that's what this slide depicts. So this kind of blackish area is where the heart muscle has been infarcted. An infarction is an injury to the heart muscle, and heart muscle cells die. They actually die. That's what infarction is. And they're replaced by scar tissue. And scar tissue doesn't contract like heart muscle is supposed to. And so if people have a large enough area of damage where there's a big area of scar, then that can result in dilated cardiomyopathy. The heart can dilate, the muscle can thin, and the contractile mechanism of the heart or the ejection fraction can become decreased. So that's how coronary artery disease can lead to dilated cardiomyopathy. Now, this slide shows some of those more less common causes. So under the big bucket of non-ischemic cardiomyopathy, many of these fall into that 10% category. Now, there is a caveat here, and I put red arrows here because some of these diseases that are on this slide actually are genetic in origin, and we know that. So like familial cardiomyopathy or inherited genetic heart disease, obviously that's genetic. Peripartum cardiomyopathy, we know now that many cases of peripartum cardiomyopathy are actually genetic in origin. And then, and I put a red arrow here because it is believed, and there's evidence to support, that there may be a genetic predisposition to the development of dilated cardiomyopathy when certain people who have that genetic predisposition are exposed to certain kinds of drugs that can be toxic to the heart, like certain chemotherapy drugs. And so, you know, maybe not all the cases are genetic, but there's a high, it's a good possibility that many cases are have some sort of genetic background to the cause. But in some of these diseases, like an endocrine and metabolic, if you have certain kinds of thyroid problems, that can lead to a dilated cardiomyopathy. Okay. Diabetes itself can lead to a dilated cardiomyopathy and obesity. If you have certain kinds of heart rhythm abnormalities where the heart rate is really fast for sustained periods of time, that can lead to a dilated cardiomyopathy. Certain kinds of infections can lead to a dilated cardiomyopathy by causing inflammation of the heart and perhaps damage to the heart muscle. One of the items that's on this slide that I think we don't actually pay enough attention to is hypertension, because hypertension is extremely common. And if you have severe hypertension that is not adequately controlled and managed, that can lead to dilated cardiomyopathy. The treatment for hypertension most of the time is pretty straightforward and pretty successful. So this is a condition that, you know, we can prevent dilated cardiomyopathy by treating it really well. So let's go to our next webinar and our next poll. This is the next webinar, next poll. And the question is, if you or a family member has DCM, what is the cause? Coronary artery disease, idiopathic, genetic, other, or you don't know? And if you don't know, that's okay. We would like to know that you don't know. We'll give you a few seconds here. Okay, let's see what we have. Okay, so I'm actually not surprised to see that a good many of you have genetic because the DCM Foundation has a focus on genetic causes of dilated cardiomyopathy. So that's good. But a lot of you have idiopathic, a few of you coronary disease, and actually more than I would like, you don't know the cause. So thank you for sharing that information. Okay, now we're going to transition into the stages of heart failure. Now, I'm just going to talk a few seconds about stages of heart failure before going on to any other slides. Stages of heart failure is a very complex concept and topic. And it's really not meant for patients to use. It's really meant for clinicians. So a lot of really smart cardiologists got together you know, a while ago, and they decided to really try to drill down and really determine how heart failure evolves. And they did that to try to provide education to clinicians and to provide some help and recommendations for when to start certain kinds of therapies. And I hope to demonstrate that to you during this session. The other important point that I'd like to make is that heart failure itself is not a disease. Heart failure is what we call a syndrome. And a syndrome is a constellation of signs and symptoms, and it's caused by a disease. So certain types of diseases lead to heart failure. And we are primarily concerned with cardiomyopathies, and specifically dilated cardiomyopathy that can lead to heart failure. So that's kind of the context of our talk today. Now, this comes straight from the American Heart Association, American College of Cardiology treatment guidelines that clinicians use to help them be able to provide the best therapies to people at the points in time when they need those therapies. And so this is how stages of heart failure are defined. Stage A, and this is an important concept, the people that fall into this category, they may not even have any heart disease when they fall into this category, and they do not have any heart failure. They're only at risk of developing heart failure. So what puts people at risk of developing heart failure? Well, I mentioned already in one of the previous slides that hypertension puts people at risk for heart failure, okay? And for the development of dilated cardiomyopathy that leads to heart failure. And I mentioned that diabetes and obesity can as well. So if you just have these conditions, or if you just have coronary artery disease, you're at risk of developing heart failure. It doesn't mean you're going to, but you are at risk of it. I've circled here something that's, I think, very relevant to much of our audience, is that, you know, if you have a known genetic mutation for a dilated cardiomyopathy, that puts you at risk. You may not have dilated cardiomyopathy at the time you had your mutation discovered, but you know, the fact that you have the mutation may it puts you at risk. Or maybe you've never been genetically tested and you only have a positive family history of a cardiomyopathy, and that history alone puts you at risk. So those are the types of people that fall into stage A. Now, stage B is when actual changes to the heart begin to occur. So we call that structural change. So in terms of dilated cardiomyopathy, the heart begins to dilate, okay? And its function may become slightly reduced. But that person may not have any symptoms of heart failure. And if they don't have any symptoms or signs of heart failure, then they fall into stage B. Just that we know, like based on an echocardiogram, that their heart has begun to dilate and maybe the function has begun to decrease. Then they fall into stage B if they have no symptoms of heart failure. In stage C, now they have symptoms of heart failure. So they have changes to their heart that we can see, like on, again, echocardiograms or other ways to image or assess the heart structure, and they have symptoms of heart failure. And then stage D is what we call advanced heart failure. So these people have rather significant heart failure symptoms that interferes with their daily life, and they've been hospitalized with heart failure despite being on really good medical therapy for their heart failure. So that's how these stages are defined. Now, we're just going to focus our attention here on the two left images. So up top here is a normal echocardiogram of a normal heart. And this is kind of an upside down backwards view of the heart, with the tip of the heart up here, and the left side of the heart is on the right of this image. So this is the left ventricle, left atrium, right ventricle, right atrium. They look normal in size, these cavity chambers, and the heart muscle thickness looks normal. We don't see the function of this heart, but this heart probably has normal function. The pictures have to be moving in order to see the function. Down here is a heart that has dilated cardiomyopathy. So it's kind of taking the heart and we're imaging it transversely. And now the tip of the heart is down here, or is up here in the corner. And this is the left atrium, and this is the left ventricle, which is quite dilated. The heart muscle is pretty thinned out here. And so this is a typical image of a dilated cardiomyopathy. Now, what we don't know, based on this image alone, we don't know that if the person whose image belongs to, we don't know if that person has any symptoms or not. If the person has no symptoms of heart failure, they're stage B. If that person has symptoms of heart failure, they're stage C at least. But if they have marked symptoms of heart failure and they've been hospitalized for heart failure, despite being on really the best therapies we can offer them, they have stage D. Okay, so this single image could be any one of these stages without knowing additional information. Now, this slide looks at stage C specifically. And what it denotes here is that there's kind of a expected course of stage C. So, most people have their, let's refer back to dilated cardiomyopathy again. Most people are diagnosed with dilated cardiomyopathy because they develop symptoms, and that is what brings them to the doctor. And they get certain tests done, and then if people realize that they have heart failure and they have a dilated cardiomyopathy. And so that's how most people actually have their dilated cardiomyopathies diagnosed. So when they present to the doctor with these new symptoms of heart failure and no previous history of heart failure, that's what this box represents. This box represents that, well, then that person gets started on the medicines to treat those heart failure symptoms and perhaps and hopefully the underlying cardiomyopathy. And in some people, those symptoms may resolve completely. Okay, they may get rid of the heart failure symptoms altogether. All right, and that's great. They're still a stage C though, because they have had symptoms. Okay, and now they're on medicines to treat those symptoms and prevent those symptoms from occurring. So that's some of the people that fall into this category here. Some other people may have initial resolution of their symptoms, but then their symptoms will come back, and they may then go on to have some persistent symptoms of heart failure, and those symptoms could be relatively minor, or they could be fairly moderate symptoms, but they never are without symptoms of heart failure again. And that's what this persistent box refers to. And then some of those people go on to develop even worsening symptoms and are quite impaired by their symptoms. And that's what this box represents. So this is called the trajectory of stage C heart failure. Now, and this is fairly representative of many, many people who have stage C heart failure, but there's not an exact course that people go through. This is just what can be expected in stage C heart failure. Now, why do people spend all this time, these experts, in trying to define all of that, those stages and what happens in stage C? Why do they spend all that time doing that? Well, that's because, again, they're trying to determine when to start certain therapies for specific people who have heart failure. And so, as I said, this is all written down in guidelines that are provided to clinicians to help clinicians to determine when to start certain therapies and what those therapies should be. Okay, so this is an example of taken right from the guidelines that clinicians use. This refers to stage A and stage B. So and I'm not going to go through this in detail, but let's just take one example. I told you that patients with hypertension are at risk of developing heart failure at some point, especially if their hypertension is not controlled. So in the green box here, it tells you what we're supposed to do, what the intervention is that we should be offering people in trying to attain in people who have hypertension to reduce this risk of developing heart failure later on. And the intervention is we need to optimally control their blood pressure. It seems like a duh sort of thing, but it's written down, it's very clear, and there's no questions about it. Another example that I've circled here is again related to genetic causes. So if let's say you as a person who has a first degree relative that has a genetic or inherited cardiomyopathy, you fall into this category of stage A. You're at risk of developing heart failure. So what's the intervention to decrease that risk? Well, the intervention is to get genetically screened and get genetic counseling. Okay, so that's the intervention. So that's how these guidelines work. So if we look at stage B here, so people that fall into stage B, and remember, just to remind you, stage B is when the heart has actually started to change. The structure and the function of the heart has started to change. So there are signs of that. But the person that has those changes doesn't have any signs or symptoms of heart failure yet. And so if we look up here in people who have an ejection fraction of less than 40%, well, they should be started on a bunch of drugs, okay? And if you have patients who additionally have this diagnosis of a non-ischemic cardiomyopathy, then they should also get genetic counseling and testing. So those are the interventions. That's how clinicians use this information. Now, when it comes to stages C and D, it gets more complicated. These are usually sicker people. And of course, in the guidelines, the treatment becomes even more complicated, and the treatment of heart failure can be very complicated. But let's just look at an example here. So right here, if a person has an ejection fraction of less than 40% in their stage C, meaning that they now have symptoms of heart failure, then these are the treatments that they should be on, okay? And then there's a caveat here. If you see where I've circled, there's this thing, it's called NYHA. That stands for New York Heart Association Functional Class 2 to 3. So if you also are, in addition to being a stage C with an EF of less than 40%, if you also are a New York Heart Association Class 2 to 3, then we have some other considerations as far as drug therapy is concerned. And I haven't told you what this New York Heart Association classes are yet, but we're now integrating with stages C and D additional information, and that additional information is this New York Heart Association class, okay? So it gets more complicated. So I'll explain to you in a minute what those New York Heart Association classes are. But first, we'll have another webinar. So if you or a family member has DCM, have you been told what stage you fall into? Simple yes or no. give you a few seconds here. All right. Whoop, can we see our oh, we should have had a percentage of that. That was, yeah, that didn't turn out very well, did it? Okay, well,
Dr. Crispell, give everyone
yeah.
just another second to get done with the poll. If you want to move left and right, we can get back to where you were at.
If I do what?
Do I need to move left or right to move back to the slide that you were at?
Move left or right?
Yeah, do we need to go forward or back?
Oh, go forward. I'm sorry. Oh, okay. Now, yeah, we can go forward from there. Oh, okay, there we go. So it's about half and half. Okay. So, okay, so about half of you have been told what stage you fall into. Okay, that's very interesting. All right, now we can go forward here. Okay, so this is a very important point. Stages, so those stages A, B, C, and D are not to be confused with functional classes. And I can tell in many of the questions that we receive that quite often people are confused and interchange the stages with the classes, with the functional classes. They are not interchangeable. They're two different things. They are used together by clinicians to help, again, to help them go through the guidelines and determine when certain kinds of therapies should be started in people, but they are not the same thing. So what are these functional classes? Well, the New York Heart Association functional classes are used to characterize symptoms of heart failure and functional capacity, or, and that's the key word here, functional, or how limited someone may be from their heart failure, okay? This applies to stages C and D heart failure, all right? It's a subjective assessment made by the clinician. So the clinician is using their best judgment and they're collecting information to be able to try to accurately assess what functional class somebody may be. And clinicians who like heart failure clinicians are very skilled at this. It requires asking people very specific questions to really try to determine, you know, what functional class they fall into. So it takes a lot of practice and skill to be able to accurately do that. Functional classes can change. They can change over time, and sometimes they can change in a matter of days, or it can change in a matter of weeks or months, or sometimes even it will take years. But it can, so you can go from worse to better, or from better to worse very quickly sometimes. Your stages do not change. So if you're a stage C, you don't go back to a stage A or a stage B. You stay either a stage C or you go on to develop stage D. But that's not the case with functional classes. You can go back and forth between all the functional classes. Functional classes can be an independent predictor of mortality, which means the worse functional class you are, and if you stay in like the worst functional class is a class 4, if you stay in a class 4, and that doesn't portend a very good outcome, okay? So that's what that means. And it's used as eligibility for treatment strategies, and that's what I showed you on that previous slide. And I'll show you again. I'll just show you another example here in a minute. But that's what the functional classes are. Now, I love this slide because if you just remember the faces of these little hearts here, you'll have a good idea of what the functional classes are. So as I said, there's 4 classes. Class 1 is basically normal. You're normal. You don't have any limitations on during your physical activity, you're normal. Class 2 is you may have some slight limitations on physical activity, but you do not have any symptoms at rest. You're fine when you're not, physically exerting yourself. But your ordinary physical activity may cause some symptoms. Now, it's very key here from the clinician standpoint to understand what your ordinary physical activities are, okay? So, for example, if you walk up 4 flights of stairs every day to your office, and you usually have no problems going up those flight of stairs, and then one day you notice that, gosh, you're a little short of breath when you're at the 3rd flight, and that's something new. Well, you may have now some class 2 symptoms, all right? Now, class 3 is you have more marked limitation on physical activity. You still don't have any symptoms at rest, but less than ordinary activities causes symptoms. So that person that can go normally up 4 flights of stairs now can't even go up 1 flight of stairs, which 4 flights was part of their ordinary activity. So they probably have class 3. And class 4 is severe limitation. And the key thing here with class 4 is that they have symptoms at rest. So they have either shortness of breath at rest, they can't catch their air, they're having problems, sleeping at night because they have to sit up or prop themselves up because of, difficulty breathing. So those are symptoms of at rest. So those are the New York Heart Association classes. And and you've seen this slide already. I'm just going to focus on a couple of different things right over here. So again, I said that we use the New York Heart Association class information in combination with these stages C and D to help determine the best therapies. So for instance, right here, this box right here, it says, if you're at stage C or D, and you have New York Heart Association class 3 or 4, and you're African American, then this drug should be added to all of these drugs, as part of your treatment regimen. All right. Another example is in this box right here. If you are a class C or D, you are a New York Heart Association class 1 through 3. And you have an EF of less than 35%, and you have a greater than 1 year expected survival, then an ICD is an appropriate therapy to be offered to you, okay? So that's how this information is used. Now, in summary, this is the last slide. I like this slide because it again shows the classes, the functional classes and the stages together. And going from left to right in both the stages and in the classes, that indicates increasing severity, okay? So you can see stage A here. These are only people at risk. They may not even have heart disease. They don't have any symptoms of heart failure. So these classes don't even apply to them, okay? In stage B, they now have some structural changes to the heart, but no symptoms of heart failure. But because they have no symptoms of heart failure, they fall into class 1, okay? Now stage C here is the tricky stage because they can fall into any of these classes, all right? And they can move back and forth depending upon how their symptoms are and how we adjust their treatments. And stage D, these are the people that are the sickest, and they basically have what we call refractory heart failure despite being on optimal therapies. And they most commonly have class 4, and sometimes class 3 symptoms, okay? So that's how we use the stages and the functional classes together to help determine best therapies. Okay, so very complex topic, and I hope I haven't confused you. But if I have, this is your opportunity to ask questions. And but I hope this was helpful to you. And we'll open it up for questions and regarding these topics.
Thank you so much, Dr. Crispell. You know, it is a complex topic, obviously, but thank you for kind of going a little bit more in depth, especially about those stages of heart failure, because it is confusing. So we do have some questions that have come in already. Again, if you have questions, just drop them in the Q&A feature of Zoom. The first question is from Jessica. My cardiomyopathy is believed to be caused by COVID. Are you seeing more cases of this? My EF was 10% at diagnosis, but I have recovered to 58%.
Yeah, you know, I'm actually not practicing right now, seeing patients face to face. So I don't really have any practical experience from, with that, but I read quite a bit. And, you know, developing a cardiomyopathy from COVID is, I think, still pretty uncommon, but, you know, it can occur, but it's still, fortunately, pretty uncommon. So, so I'm glad that you have recovered. It sounds like you've had a really nice recovery. So that's great. I'm glad to hear that.
Next question. What is considered hypotension blood pressure?
That's a great question. Hypotension, blood pressure is really when you have symptoms. Don't focus so much on the number. It's really when you feel that you have symptoms of low blood pressure. And symptoms of low blood pressure commonly are lightheadedness and dizziness. So like, for instance, many of the medications that we give people for their heart failure can lower their blood pressure. And sometimes, you know, shortly after people take those blood pressures, they may have symptoms of lightheadedness or dizziness. You know, so that could be a symptom of low blood pressure. Okay. That's probably the most common symptom. Another symptom that I always pay attention to, and in my clinical experience, if a patient tells me that they have a feeling like they are seeing bright lights, or they're going through like a tunnel with like bright lights, that can be a symptom of low blood pressure. Okay.
Oh, interesting.
So low blood pressure is really more how you feel than the actual numbers. It's very easy to get fixated on the numbers. Now, granted, we do start getting a little concerned when the numbers get to certain levels, but I think that you know, it's more how you're feeling that should drive what we do.
Okay, great, thank you. Let's see. If you have or have had DCM, if you've been diagnosed and are in heart failure stage C, resolved from a previously enlarged heart and low ejection fraction, do you still have DCM or just heart failure stage C?
Yeah, you still have, you still considered to have stage C. And, you know, so there are subcategories, and I didn't go into that, but there are subcategories of which are in the guidelines that actually do characterize people, like if they have had improvements in their ejection fraction, if they've normalized their ejection fraction, if they've had some shrinkage of their heart size, you know, that's all good. And there's actually some categories that capture those, you know, those people. But you're still considered to be in that larger category of C. Okay.
And would the person still be considered to have DCM?
Yeah, because it's, you know, we know that the medications in some people, not in all people, but in some people, the medications can actually cause the heart to decrease in size and the ejection fraction to improve. If we take those medications away from them, then they will go back to having a dilated heart and having their ejection fraction fall. So in the guidelines, it's very specific that those medications are to be continued, even if they've had improvement in their ejection fraction or even normalization of their ejection fraction, because those medications have modified, they've modified the disease process. Okay. And if we take those modifiers away, the disease process will continue.
Thanks for the clarity on that. There's a related question. If you have a genetic mutation with DCM and eventually need a transplant, will the genetic mutation affect the new heart? So would you still have DCM?
Yeah, that's a good question. I don't think so. I don't believe so.
Okay.
And we transplant now. We know that a lot of people that we are transplanting into have certain kinds of genetic mutations, and the transplanted hearts, they don't have signs of developing the changes associated with that genetic mutation.
Okay. All right. Great. That's very positive. That's good.
Yeah, very positive.
Let's see. My husband's father has DCM, and my husband drank heavily prior to diagnosis. Do one of these causes carry more weight in a diagnosis? The genetics versus the drinking, or the combination of the two?
Yeah. That's a really good question. I mean, there is such a thing that is called alcoholic cardiomyopathy, and most of the time it is a dilated cardiomyopathy. It's kind of controversial, because it actually varies by. It's interesting, like in Europe, they diagnose the frequency of alcoholic cardiomyopathy is different than the frequency in the United States. So it's basically how we're diagnosing it. And there may be a genetic background to people who may be very sensitive to alcohol and leading to a dilated cardiomyopathy. I don't think we have any definitive genetic information to actually prove that, but that has been hypothesized. And but we do also know that alcohol in large quantities is actually toxic to the heart muscle, and so it may be a combination of things. So,
okay, great. Thank you for answering that one. We have a bunch more coming in here, so let's try to let's try to roll through some of these. Where do most folks come into the model? So I guess, when are most folks diagnosed?
Yeah, stage C.
Okay.
Yeah.
That makes sense.
Now that may be changing because like with this audience, this is a fairly, this audience for this webinar, 50% of the audience for this webinar have a genetic cardiomyopathy. Now they may have been diagnosed by being screened genetically, and maybe they don't, have symptoms of heart failure. It's hard to know. So the landscape is changing a little bit, but it has been that most people come in to the stages at stage C. That's when they are identified.
Are there any common paths and timeframes with DCM as you progress through the heart failure stages? I guess everybody's different.
Yeah, everyone is a little different, but that's what that stage, that trajectory of stage C slide was trying to show, that even though everyone's kind of is different, unique, you can have. I think what the point that they're trying to make in that particular slide is that you can expect certain things to kind of happen in the person that has stage C. Now, will it always happen that way? No. And there's some variability built into that slide, so people can get better, they can stay better, or they can get better and then they can get worse again, and that they can get better again, or they can continue to get worse. I mean, so there's those scenarios within stage C. So, you know, as a heart failure specialist, you have to be aware that people can, within stage C, have a trajectory that is represented within that slide, okay? And it may not be the same for every individual.
Okay. Well, this is a great question. Why are so few folks, sorry, easy for me to say, genetically tested if it's in the guidelines?
Yeah, that's a really, really good question. Well, these are brand new guidelines. So let me just say that, okay? And you're actually getting hot off the press information here.
Okay.
So these guidelines are available online right now, but I don't think they've been published in paper form yet. So they, you know, their distribution is somewhat limited right now. So that's one reason. Second, another reason is, you know, in the world of medicine, in healthcare, change comes by pretty slowly. It's hard to make changes. And it's hard to get people to change their behavior. It's hard to get physicians to change their behavior, to tell you the truth. So, you know, it sometimes takes a long time for people to get the message, for them to understand why we need to do this and why it's important. And so some of these changes come about very slowly. But I am very encouraged, and you as patients should be very hopeful, because it is now in the guidelines. It is very clearly stated in the guidelines. Good. So that is a very important and hopeful thing.
Okay, excellent. Just another like one or two questions here we have time for. What would you say is the most important marker in an EKG to pay attention to in relation to monitoring DCM?
Boy, that's a great question. You know, so just generally speaking, I would say it's the presence of a left bundle branch block. And the reason for that is because in the guidelines, if you have a left bundle branch block and it's fairly severe, and we measure it by measuring how long the block is on the electrocardiogram, and if it's a long, wide left bundle branch block, 150 milliseconds or greater, then that is a criterion. If your ejection fraction is you know, less than 35% for like a biventricular pacemaker. And so so your therapy, it may alter the therapy that you're getting. So that's why it's probably a very important sign on the electrocardiogram to pay attention to.
Okay, excellent. And then is there a safe form of exercise you could recommend for stage C? I mean, it's probably all individual, and that's the last question we'll take for tonight. So go ahead.
Yeah, I don't know that you know, there's any safer form than another. I think it really depends upon what you like to do. But certainly walking, you know, and walking is so underrated. I believe, you know, walking is a great exercise, and you know, so you know, certainly walking is good. And if you can walk, or you know, fast walk, or riding a bike, you know, maybe you don't like to walk, maybe you would prefer to ride a bike, you know, that's great too. You know, any form of aerobic, I think, exercise. And if you can determine like length of time you can do that, or measure it in some way, either in blocks or again in minutes or whatever, then, you know, and establish a baseline for you. You know, what can you do comfortably? And at what point, you know, it's harder for you to go beyond that because you start getting short of breath or you start getting really fatigued and you need to stop and rest. Those are important things to really pay attention to. So establishing some form of, exercise that you enjoy, I think, is the most important thing. But walking is certainly easy, doesn't require any going to a gym or no additional costs. And you can measure it off in minutes or by blocks. So it's pretty easy to keep track of.
And if there are any questions that we didn't get to tonight, we haven't, I think there's only a couple, we can maybe answer those and roll those up along with the presentation. There is one last one that I just wanted everyone to hear because I think it's really important. The question is, with DCM, an improvement in ejection fraction from less than 29 to 55, can medications be discontinued? I know your answer, but go.
No, the answer is no. Yeah, I mean, that is great that you've had an improvement. You've normalized your ejection fraction. You do not want to risk that. You don't want to risk the great progress you've made. And those medications are what has gotten you to the point that you're at. You do not want to discontinue them.
Excellent. So thank you so much again, Dr. Crispell, for your insight. We had a couple of comments thanking you directly for explaining the stages so clearly. And thank you to our audience for all of your questions. We just have a couple more slides, and I just wanted to first say thank you to our generous sponsors, without whose assistance we could not bring you these webinars every month. You see our generous sponsor logos listed there. And then for the next slide, for those of you who haven't already, please go to the dcmfoundation.org, where you can find all kinds of resources about dilated cardiomyopathy. And we also encourage you to follow us on social media, Facebook, Instagram, Twitter, LinkedIn. We provide updates weekly, often multiple times a week, especially on Facebook and Instagram. And that's a really great resource for additional information. Last but not least, please hold the date for our next webinar, which will be on Wednesday, May 18th at 6 p.m. Eastern Time. And this is on the topic of therapies and hope for laminae-related DCM patients. So you won't want to miss that. Thank you again to you, Dr. Crispell. Thank you to Heather, as always, behind the scenes, helping us with Zoom. Again, everyone, thank you for joining. Stay safe, be well, and we hope to see you next month. Okay, take care for now. Bye, guys.
Bye-bye.